I'm a consultant esophago-gastric surgeon at Royal Surrey Hospital. My main kind of focus is both benign and also cancer surgery. I've got a specialist interest in minimally invasive, so keyhole surgery, and do robotics, both cancer treatment and also benign surgery, such for reflux disease, hiatal hernia repairs. I've also got a specialist interest in endoscopy, which is camera tests to assess the esophagus and the stomach, of which do perform assessment and treatment of Barrett's esophagus, which I'll talk a bit about, and also removes lesions with the use of endoscope as well. I'm based at Royal Surrey, but I do private practice at the private GP clinic at West Byfleet, Nuffield Hospital at Guildford, and also Mount Alvernia, part of Circle Health. Bit of my training, I did majority of my training in the northeast at the Northern Esophago-Gastric Cancer Centre, one of the biggest in Europe. So my talk is going to be a bit about gastroesophageal reflux and what that means, or what it means to people, and also so we talk about reflux and dyspepsia. It's kind of two common words I use for people. So people say dyspepsia, or medical professionals say dyspepsia, and that encompasses a huge range of symptoms. So simple as just upper abdominal pain to reflux, where people describe kind of fluid or irritation coming up the back of the throat or behind the sternum, nausea, vomiting, and the classic symptoms of heartburn, which is that discomfort. And it's kind of encompasses a wide range of symptoms. It's very common. About 30-40% of the population have one of those symptoms at some point, or persistent symptoms. And what we talk about gastroesophageal reflux is that condition where you've got excessive stomach contents coming back up into the esophagus. So is that the reflux? Is that one specific kind of condition that we say is when you've got contents in the stomach coming back up, and that can vary on what symptoms it causes, and that's why we group it into that two different types. So before we start talking about the disease, just talk about what the normal state is. So we start with the esophagus, which is this long tube that starts up in your throat where the food enters, the swallowing mechanisms takes place, and the food travels all the way down the esophagus into the stomach. Now, the esophagus is divided into three parts. A small part of it is in the neck, the majority of it is in your chest, and the small part is then in your abdomen, just below the muscle called the diaphragm. Now, it's a tube which is essentially consists of muscle layers, and it propels the food along those layers. Now, as it enters into your stomach, the junction between the esophagus and the stomach, and that's the mechanism that allows food to go down, but prevents any contents from going back up. And we talk about reflux, this kind of mechanism, or the way it functions is important, how we understand it. And it's failure of one of these mechanisms that then leads to predominantly to your reflux that people suffer from. So we'll just talk to you about the different components and why that's important. So as I said, the gastroesophageal junction is where the esophagus enters into your stomach. Now, in normal terms, this junction sits below the muscle called the diaphragm. The diaphragm is a muscle that separates your chest and the abdomen, helps with your breathing. When it allows food to enter into your stomach, it prevents anything going back up. And this is important because food can stay in your stomach for up to 2 to 3 hours, and it can take time to empty. So if your stomach is full and this mechanism is not working as well as it should, contents will go back up. And that's what people normally encompass when they got symptoms of reflux after meals. So 2-3 hours after, so feeling full, and they get the reflux symptoms. So how does your body kind of prevent this from happening? So it's got three components primarily to it. So the first component is the pressure in your abdomen is different to your chest, and as long as this junction sits below the diaphragm, the pressure in the abdomen is higher than in the chest and keeps that kind of external pressure, keeps that valve closed. The diaphragm, again, is that muscle that prevents that junction from going up, and again prevents food contents going up. And the bottom end of the esophagus, where it joins the stomach, it's got a muscle layer around it, a stronger muscle layer that kind of contracts to prevent food from going back up. And also the way the stomach and the esophagus sits in the abdomen. All of these three components help prevent the food in your stomach going back up in normal cases. And it's one of the failures. Each one of these mechanisms, or potentially multiple mechanisms, can fail, can then lead to reflux or predispose people to reflux. And understanding that can help understand the condition and how best to treat it. So one of the things we talk about is the pressure in the stomach. So especially if you've got increased pressure in your stomach, and the common part of it is weight. So if you have a raised BMI, you're more prone to reflux because your stomach, the weight of your stomach increases the pressure on the abdomen, and essentially the food is essentially forced back up because your stomach, it can't hold the pressure in the stomach is too high. The mechanism is going to hold so much, and after big meals, can feel sick or reflux when you're lying flat. And losing weight is one of the most successful ways of treating your reflux. Reducing your BMI from 35 to 30 or even lower can significantly improve your reflux type symptoms. The next step is kind of what we call conservative management, lifestyle measures. So all of these things, components, are there to allow your stomach to empty, prevent the food from sitting in your stomach too much, and therefore prevent this reflux symptoms from happening. So smaller meals at regular intervals important, so allow your stomach to empty, not keep your stomach full, reduce the pressure inside the stomach. Avoiding large meals before you go to bed. So reflux is one of those symptoms quite common at night. So preventing large meals before you go to bed is quite important. Make sure your large meal is not the last meal before you go to bed, and have at least 3 to 4 hours before. And also preventing dairy, alcohol, all of these impede your emptying of your stomach, so they can have an impact. The third thing is smoking cessation. So why is smoking cessation important? So the nicotine in smoke essentially relaxes muscles. So going back, that muscle at the bottom end of the esophagus, if it relaxes, then again, it can allow stomach contents to go back up. And nicotine is a muscle relaxant, so smoking not only predisposes you that muscle relaxant aspect of it, it can also cause ulceration within the stomach as well. So it's important for a number of reasons. Reducing alcohol intake, and again, this corresponds to the fact that it can impact with gastric emptying and therefore predispose to have reflux and cause irritation. So when people have reflux, the main kind of things is simple things to start off with, addressing one of those things that can fail, and sometimes simple measures all that's needed. However, it's difficult. Sometimes a combination of things is what's required, but potentially simple things to start off with. Now, we then talk about medication. So one important thing of treatment of reflux is a combination of what's called conservative management, so simple measures, plus or minus combined with medication. And a bit about how medications work and why they are effective in some people and not others. So simple medication, so over-the-counter antacid medication, Gaviscon, Rennies, what do? Essentially, they coat the lining of your esophagus, stomach. So all it does is when you've got the contents coming back up, the acid doesn't cause any irritation. So things are still coming back up, but that irritation isn't happening because there's a protective barrier. Acid suppression medication works on a different principle. So they can take up to 2 weeks to work. So when you're starting on medication like lansoprazole, pantoprazole, they take a couple of weeks to work. So sometimes just being on medication a couple of days, you may not get symptom relief. The reason is because these medications work on reducing the stomach acid produced in your stomach. And what they're meant to do is by reducing the stomach acid, it prevents the stomach acid to go back into the esophagus and cause irritation. So you may still have the symptoms of fluid or coming back into the esophagus, it's just they won't cause irritation, and that's a main aim is this medication. So they don't prevent reflux, but they reduce the inflammation, irritation caused by the reflux. You can take them up to twice a day, and in some people, titrating the dose is important. So some people, the same dose doesn't work for everyone. Some people you need to increase it or take it twice a day. And the important thing is they work by shutting down the cells that produce the acid. But they only work if you take them prior to meal. So you need to allow the medication to get in, shut those cells down before you have a meal. Because before you have a meal, when you start having a meal, the acid's already produced. So there's no point taking the medication beforehand. And all you're then doing is the delayed response is not going to work. So PPIs is kind of the common name for these medications like omeprazole, lansoprazole, pantoprazole, huge family of them. And then there's another family called ranitidine, famotidine. These all, again, they work on a different aspects of the cells that produce acid, but again, same mechanism. So sometimes a combination of medication is needed to help with these symptoms, but in majority of the people, lifestyle measures plus some medication can help relieve, in most people, the symptoms. So when do we think about investigating reflux? So most people, when you have reflux, you have the one-off episodes, medications, or sometimes lifestyle measures is all you need, and your symptoms get better. But in some people who the medication is not helping, or they're having persistent breakthrough symptoms, or the current guidelines is if you're over 55, you're having persistent reflux, the advice is to get a camera test, which is an endoscopy. And that's kind of the gold standard that we use to investigate reflux when you get referred to us in the hospital, once you've had simple measures. So what is an endoscopy? So an endoscopy is a camera test, which is used to assess the lining of your stomach and esophagus. It's performed as a day case. The camera itself is a long tube, and essentially you attend the endoscopy department, we do a few tests, and it can be done under what's called awake sedation, so we give some medication to make you a bit drowsy, and we also give you some spraying on the back of your throat. And we place the camera, so going back, I'll go back a few slides, so we place the camera in your mouth, and then it enters the esophagus, and it goes all the way into your stomach, into the first part of the bowel called the duodenum. And it's a good test because we look at the lining of the esophagus, and we look at the lining of the stomach. We also look at the duodenum, which is the first part of the bowel. It's quite an important test because it can help identify if there's any other causes for your reflux, particularly exclude if there's any cancer and other serious conditions or ulcers and so forth. At the same time, in the endoscopy, we can take pictures and also samples, so biopsies, which are little bits of lining from the esophagus and stomach. Important thing is when we do endoscopy, in particularly investigating patients for reflux disease, is to assess how bad reflux is. And as I said, going back, when you're on acid suppression medication, you're reducing that inflammation in the esophagus. So truly assess how bad your reflux is. It's a bit of a kind of catch-22. You come off the medication for 2 weeks, do the test to see how bad this reflux is. So sometimes, in most times, that's the best way to do it. To come off the medication, do the camera test, see how bad the reflux is. In some people, that's fine. In some other people, it's not tolerated because the symptoms are so bad. But the endoscopy is kind of the gold standard in identifying the reflux, how bad the inflammation is, and are there any precipitating causes for it. So one of the important things is differentials. If you're having persistent reflux or difficulty swallowing or this discomfort, is to make sure we exclude cancer and inflammation. Now, when we investigate endoscopy, you can end up with three things, more than three things that we look at. So the first thing is something called Barrett's esophagus, or potentially cancer. So this is Barrett's esophagus, a condition where your esophagus is exposed to acid for a chronic period of time, and the lining of your esophagus changes to that of the stomach. And this change is important because that change can, if uncontrolled, can lead to cancer. So when we do an endoscopy, if you find you've got Barrett's esophagus, we take samples and we keep you under endoscopic surveillance. So we'll need to keep an eye on that area. And sometimes it's camera tests every year, or 2 years or 3 years. It depends on the length of the Barrett's esophagus. Or we do the test and we find, unfortunately, you've got there is cancer there, then we'll take some biopsies and treat it accordingly. The second kind of common findings we do is we find there's inflammation of the esophagus, or esophagitis. And that is because your esophagus has been exposed to chronic amounts of acid. The lining gets red and raw. And that treatment is essentially being on high-dose antacid medication, suppress the acid for a period of 8 weeks, and we repeat the camera test to make sure it is all resolved. So if you have this kind of severe inflammation, we'll treat you with high-dose medication, bring you back for a camera test in 8 weeks to make sure there isn't anything else underlying. The third thing is sometimes we do the camera test and we find actually it all looks normal. Now, does that mean you don't have reflux? Not necessarily, and I'll come on to that and why that's important. So going back, I talked to you about Barrett's esophagus. So this is kind of what we normally see. I'm not sure if you can see my mouse, but the lining of the esophagus changes to that of the stomach. And if you have this condition, it's important you're under surveillance, you have a camera test, at regular intervals, depending on the length, 2 year, 1 year, 2 years, or 3 years. And it's done in a specialized center which looks at that, because this is a condition that can potentially turn into cancer. And between that and cancer, there is different kind of areas. So at the bottom picture, sorry, I'm not sure if you can see it, but is when you get these little nodules that can arise. So that could be cancer, it could be very early signs of cancer. And these kind of nodules we can remove with an endoscope, with a camera. So you can potentially treat early cancers this way as well. So that's why it's important. Picking it up early, we treat it early, your outcome's a lot better. And that's why it's important. And it needs to be done by specialists to look at this area and to treat it. When we do camera tests, we pick up something called a hiatal hernia. Now, what does that mean? So I'm sure people read about it. What does that mean, and is it serious? And how does that affect its reflux? So going back, as I said, your normal esophagus, that junction between your gullet and your stomach, needs to sit below the diaphragm. When you have a hiatal hernia, that junction is now slipped up above the diaphragm. And when that happens, as going back, that mechanism, one of your, or two of your mechanisms failed. That diaphragm now is not going to help control food entering down and food coming back up. That kind of mechanism has failed. As a consequence, you're more prone to reflux. So if you have a hiatus hernia, inherently more prone to reflux. There are different types of hiatal hernias, but they can, a majority of them, if you have them, the commonest is the sliding type, where essentially that junction is moved up. Quite a common finding. Commonly, as you increase with age, that muscle gets weaker. You're more prone to have this finding. The type 2 and type 3 are rarer, is where part of your stomach moves up along with the junction. Again, it's a rarer condition, but again, we do see it, and your symptoms will be similar. But presence of a hiatus hernia and reflux is again more prone to it. So, and that's where surgery can sometimes play a part. So we found, going back to our previous slide, we've found someone who's got erosive esophagitis and they're on the medications. The medication helps control it, or they've got a normal test. So you've got someone who's got symptoms of reflux and they've got normal endoscopy, but does that mean they don't have reflux? That's when we start doing something called esophageal studies. So these are, although I've put down as 3, there are 2 essential studies. One is essentially what you're now monitoring is quantifying your reflux. How bad is your reflux? How frequently getting it? And how strongly does it correlate with your symptoms? So the first is where you put a probe, essentially, where through your nose into your stomach, the bottom end of the probe, and the probe sits all the way along your esophagus at different points. And what the impedance study does, essentially, it will detect what's coming back up. Is it liquid? Is it gas? Is it mixed? And it's meant to correlate with your symptoms. So when you say, oh, I'm getting a bit of reflux, you press a button and it'll say, right, what are you actually bringing it up? Is it gas? Is it liquid? Or is it a bit of both? And that's quite important because it'll tell us what kind of reflux it is and how best to treat it. Because if you're mainly getting gas and there's bloating and so on, that is not true reflux, that's mainly gas, but liquids and acid and so on is quite important. And that's where the pH probe comes in as well. So there's a little probe which tests the pH. So it'll say, is it acidic or is it non-acidic? So you put it over a 24-hour period, you have a monitor, and every time you get reflux, you press a button. The probe will detect the readings over a 24-hour period, and it will correlate with when you're pressing the button. So it will correlate if your symptoms relate to this low acid. So you'll be off your antacid medication for 2 weeks prior to this test. If you have any acid coming back up and you correlate with it, that kind of is a strong correlation. A weak correlation is when you say you've got reflux, but the probe is not picking up any acid. And it will do it over a 24-hour period, and it'll give us a value and a report. And it's done by specialists. So this is a study done by specialists who just do this day in, day out. The other probe is, this is something that's done on the day, where it's a probe that's, again, sits in the esophagus, to pass through your nose into your stomach. And this is to measure how well your esophagus works as a muscle. So we get you to drink liquids, and then also swallow marshmallows, sometimes also a bit of, essentially something to test how well your muscle works. And it gives us a reading to see how well your esophagus is working and it'll give us again a readout to see, is your esophagus working like a true muscle, contracting from the top to bottom? Is it contracting at all, or is it very irregular? And that's quite important when it comes to an operation, because if your esophagus is not working as well as it should and there's a bit of dysmotility, doing an operation to help with reflux is not a good idea. And that's the reason why, considering an operation, you need to have these studies to assess how bad your reflux is and whether an operation is suitable. So patients come to us with reflux, we do these studies to assess, and we essentially get a score and a report saying, based on the studies that you've had, you've got what's called pathological acid exposure. So you've got reflux, which is correlates strongly with your symptoms, and there is a significant amount of acid coming back up. And in those people, potentially, if medication not helping the symptoms, then an operation may help. And then there's other group of people, we do these pH studies, and it comes back as saying, yeah, they are saying they got reflux. It is kind of, but the reflux it's well within the normal range, so coming back up, but the symptoms are quite strong. What does that mean? So that means that you've got what's called a hypersensitive esophagus. So the lining of esophagus is just more sensitive than other people to small amounts of acid. And in this group of patient, is what we find is sometimes antacid doesn't work, and it may be putting on some medication to help kind of numb that esophagus area. So trying to be on medication called gabapentin and so on that can help treat that kind of symptoms. But again, you're looking at subset specialist people to look at that. And then you've got the kind of the second group of the people who've got acid that's kind of normal within the normal range, but doesn't really correlate with the symptoms. What does that mean? Then it means essentially functional heartburn. So there's no real kind of mechanical cause for what the symptoms are getting, and no real kind of sinister pathology or any significant problem. And it's a case of managing it with symptoms. So it's quite a complex when you're looking at these smaller subsets of people, is looking at a whole host of things, and sometimes putting a label on people is wrong, but this kind of, I say diagram, but this kind of helps rationalize why we do something and why we're doing something, because we need to have a strong correlation with symptoms and your studies and the camera tests to definitely say this how best to treat it. So this comes back to when should we consider, when should a patient consider surgery? So if people find that their lifestyle measures and medications are not helping with the symptoms because they find that their reflux is too bad, the medication not helping, we do the studies, they say they've got reflux, we quantify it, yes, they've got severe reflux, they don't want to take medication, then we think about an operation. Or they just don't want to take medication on short term. So you get diagnosed with reflux at age 30, 35, you say, I don't want an operation, I don't want to take medication for the rest of my life, then we think about an operation. But the success of this operation is dependent upon us going back to, you need to have good correlation with your symptoms, the endoscopic findings, and the study. So if you meet all those three things, the success of the operation is that much higher. Not to say if you have one of those three things, the success of the operation is less. So talking now a bit about operations. How do we do the operation? So anti-reflux surgery is kind of the banner that we say it, but essentially the principle is the same. Essentially, if you've got the hiatus hernia, that's that weakness in the diaphragm muscle, we pull that junction down, we repair it, and we reinforce that junction with a bit of the stomach. Majority of the time we do it keyhole, and now over the last few years we've established robotics, so we do robotic anti-reflux surgery. Why is that important? The cuts that we make, although they're small, the robot facilitates much easier for us to do the case, and in terms of recovery, either you do keyhole, laparoscopic, or robotic, you're essentially an overnight stay and you're home the next day. And this is kind of the operation that we do. So the one I do is what's called a toupee, but essentially the medical terms of it aside, the principle is you reinforce the bottom end of the junction between the esophagus and your stomach with the stomach itself. So you wrap the stomach around the esophagus, the bottom end, and that kind of reinforces it, so allows that junction to work a bit better. But it's a two kind of principle thing. We bring the junction back up into So going back in the slides, we essentially try and recreate the normal anatomy, which is bring that junction back up into the below the diaphragm and then reinforce it with the stitches. So procedure normally takes about an hour and a half to do, and as I said, it's overnight stay. So because we are recreating the junction between gullet and your stomach, we keep you overnight. We make sure that you recover from the operation. And one of the important things is after the operation, it's very strict dietary. So you'll need to be on liquids in the first 24, 40 hours, and we'll build you up gradually. You'll be able to go on the next day, but all intake will gradually be phased because there is a bit of inflammation around that site. It will take a little bit of time to heal. But in terms of recovery-wise, it's keyhole. You'll be back to your normal functional activity within the week. No heavy lifting for about 4 or 6 weeks to allow things to heal, but otherwise normal activity. Now, doing this approach, the 5-year follow-up, the success on studies have been about 80 to 90%. The success is based on being off medication. So, 9 out of 10 people at 5 years are off medication and the symptoms are controlled on surgery alone. But this is based on choosing the right people. If you do the right operation based on your symptoms, based on the physiology studies, that's how you get the success of 80 to 90%. And if you, as I said, going back, the weaker the symptom correlation, the weaker the kind of the reflux that based on your studies, the less the success. So it's very much, discussing your symptoms, assessing your severity, and then deciding how best to treat it. The other important thing to think about is also the weight. So anyone with a BMI of 35 or greater, I wouldn't advise them to have an operation, anti-reflux operation, because you're not treating one of the big underlying factors is the increased pressure in the abdomen. You do an operation, it's going to fail in the short term, for sure. So anyone with a BMI of 35, they find they can't reduce the weight significantly, you've got better outcomes having bariatric surgery, which will not only help lose weight, but also treat your reflux. So BMI 35 and above, advise bariatric surgery. Less than 35, 35, again, can have the operation, your success is going to be that much less than if you're less than 35. But sometimes losing weight is all that's needed. But that's what's important. Long term, what does it mean? I said over a 6-week period, we gradually increase your intake. You'll be on a normal diet. But it does have side effects to the operation. People can get bloating because they can't kind of burp as well as they could, can't vomit as well as they should because you kind of reinforce that mechanism. And the hiatal hernia can recur. So sometimes that wrap that we've recreated can slip back up into the chest. Not serious all the time. Most of the time, symptoms are controlled, but it can happen. But it's about 5-10%. So over a 5 to 10 year period, 1 in 10 people can have this recurrence. But that doesn't really mean you'll have symptoms again. And if you have symptoms again, we reassess you and then think about whether we need to revise the surgery. But revisional surgery for this is it's increased risk. So it's kind of, again, reassess your symptoms. Is it the right thing to do? But that's a patient conversation to have. Over the last 10 years, there's been more advances in how best to treat reflux other than medication and surgery alone. Surgery remains the gold standard. It's the best in terms of long-term outcomes. There's good evidence base behind it. Choose the right person to do it, do the operation, keep the symptoms, you have better success. But there are newer treatments on the line. There's a few I've listed. One is called Stretta, which is an endoscopic treatment where you place an endoscope and you essentially burn the junction between your gullet and your stomach, and you essentially make it thicker, the muscle thicker, to prevent the reflux from happening. Again, one kind of caveat is all of these studies, these newer devices have only come online the last few years, so the long-term outcomes are not known. But again, Stretta, it works in some people, doesn't work in all. So again, selection is important. There are other mechanisms where we essentially use the camera to reinforce the junction using this device called the EasyFix. Again, newer device that come online. And then this new device is called the Lynx, which is a magnetic bead that you put around the bottom end of the esophagus. And what the principle is, when you allow food, the magnet will open up, allow food to go through, but it won't prevent anything coming back up because the magnet is strong. So it'll prevent things from coming back up, but allow things to go down. And that's the device. But again, it involves a keyhole operation to put this bead around the bottom end of the esophagus. Again, it's just coming online. None of these are offered on the NHS. In the NHS, they're offered in select patients. So this is more purely, trial based at the moment. So that is a kind of a whistle-stop tour of gastroesophageal reflux, how we assess it, what the symptoms are, how we investigate it, a bit about medical management, how we treat it, and why we do operations, or how we do the operations, and how we achieve success. So but I said a bit about myself. So I practice at the private GP clinic, West Byfleet, alternate Fridays, 2 to 5 p.m. I'm also based at Circle Health, Mount Alvernia, and the Nuffield at Guildford. Cool. Any questions?